Shropshire in 2009 with 5 clinics, 5 clinic bases, 8 clinics a month. New referrals were all seen by doctors, nurses saw all the reviews. We had 18 new children a month, 65 reviews. And the waiting time, which is why I sort of started a project, to look at the fact we've got 26 weeks waiting time in 2 of the clinics. If doctors weren't there, no new patients were seen. And in April 2010, 5 clinics were cancelled because doctors weren't available. So that's 15 new patients that weren't seen, so the waiting list went up and up. In that same time, there was no clinics cancelled by the nurses. So it was sort of another string to the bow that said, you know, we need a nurse-led service. The treatment depended on the doctors and nurses, and they were all slightly different. It struck me that I used to cover clinics in the holidays at times, and I'd go to other clinics and I'd want a piece of paperwork and I knew where everything was in my own clinic. I went to somebody else's clinic, I didn't know where anything was. So one of the ways was, if I did a care pathway, made all the clinics the same, it was easy for nurses covering all the clinics. As I say, there's 5 bases, and Shropshire is the largest inland county. So from my base in Oswald Street to the base in South Shropshire is 49 miles. So if we're covering clinics, we need all the equipment there because we're likely to be rushing. So the care pathway policy was developed from support from the Queen's Nursing Institute Fund for Innovation. It's a working document, it's changing all the time, and there's the policy, there's the pathway, and there's the patient leaflets as well. They're all in the same area. And as I say, the main thing is the funding of projects. I was struggling, I was thinking about doing nurses clinics in the care pathway, but I was doing some of it in my own time. With the funding, I had time to do it. And that's what we need sometimes. We just need that time out of our caseload to concentrate on what we're doing. So the project, the aim is to provide a quality service to children with any races within Shropshire, and I had 3 aims: to do the care pathway, to reduce the waiting times and DNA rate, and to increase knowledge. By the nurses getting more knowledge of the care pathway and all the information that's in that, then they can partake that information to parents and children. And the waiting times and DNA rate, we had 50% DNA rate at one time, which was sat around in the clinics doing nothing, waiting for people to come. It's a waste of our time, waste of parents' time. As I say, there was a 26-week wait in one clinic, and that was the one that was the highest DNA rate, and I think that's because they'd had the appointment too long. As of now, we've still got 5 clinics. We've got 10 clinic sessions a month. We're seeing 25 new and 50 reviews. The reviews have gone down only in the fact that because we're seeing more reviews. And then we've got the capacity, we haven't got the capacity, should I say, to see some of the reviews. So what we started doing is there's 3 of us that work all year round. So in the school holidays we're doing ad hoc clinics to catch up on the reviews. We're fully nurse-led as of the 1st of February. We've currently got a community paediatrician doing a specialist clinic in the centre in Shrewsbury, and that's for the complex ones that we haven't been able to deal with within the clinics. And our work's based on Richard Butler and NICE guidelines. NICE guidelines, again, you know, pediatrics is not the child's fault. Offer support and assessment. Don't exclude younger children. We've always seen in Shropshire children from 5. No children are going into school at 4. We're still only seeing children at 5, but we are giving support over the phone for younger children. Current situation, staff morale, job satisfaction have improved. Anecdotally, the nurses say they like being able to care for the child from the beginning. Because we work in the schools, we've got a good link with the schools if we're looking at fluids and getting them to drink more in schools. So say we've got good job satisfaction. Children seem to be going through the service a bit quicker as well, because I think they get to know this, rather than getting to know the doctor and then getting to know the nurse, they know the nurse from the beginning. I've got a dedicated team of 12 nurses doing 5 clinics. They want to be involved in any races. They're an enthusiastic bunch of nurses, and that's what we need. The care pathway supporting all the nurses. And now we've got a system called partial booking, where parents get a letter inviting them to ring in for an appointment. They ring in, make the appointments convenient for them. Then 2 weeks before the appointment, they get a letter reminding them. And if they need to, they can cancel. So the DNA rate has dropped dramatically. It's practically disappeared altogether. We do get some cancellations, but the DNA rate is practically nil. As I say, I managed to work in Oswestry in North Shropshire, and I used to have 10 appointments and 4 or 5 would turn up. Now there's 5 appointments, but all 5 turn up. So it's better use of our time as well as parents' time. We're also doing telephone contacts to parents on referral to give the basic advice, and between clinics if you need to. We're trying to be a bit more proactive, thinking about fluids in schools. We're also exploring about more complex cases, whether it's a nurse specialist, whether it's integrated continence service. In the longer term, issuing desmopressin at the minute, if patients come to the clinics, if they need desmopressin, they've got to go to the GPs to get the prescription, and you know, it's such complications of them following up or not, and not giving the correct fluid advice and things.